Good afternoon, everyone. Hopefully you can hear myself and Rowena.
Hello, good afternoon.
So, Ro, should we just do a quick introduction before we get started? So, good afternoon. My name is Laura Charlesworth. I am an associate professor in the School of Health and Social Care at the University of Lincoln, and my role is that I oversee our allied health professions programs, which I'm going to tell you about a little bit more in a moment. So, I'll hand over to Rowena just to say hello.
Hi, I'm Rowena, or Ro. I'm the programme leader for the MSc Physiotherapy pre-registration programme, so the programme at the University of Lincoln in the School of Health and Social Care for training physiotherapists, and I'm a physiotherapist by background myself.
Lovely, thank you, Ro. Do you want to move to the first slide, Ro?
Yep.
Okay, so before we do the fun stuff, and hopefully you've all got some equipment to hand, which we'll talk to you about in a moment, I just wanted to tell you a little bit about the allied health professions. Now, we often abbreviate allied health professions to AHPs. It's a bit easier to say, and we use the term quite a lot. So both myself and Rowena are an allied health professional. So Rowena's already told you that she's a physiotherapist, and I'm a radiographer. But the actual allied health professions make up a whole number of different health and social care professions. So we describe ourselves as a family, and depending on whether we talk about the AHPs in England or the AHPs in Wales or Scotland or Northern Ireland, we're either 14 or 15 different professions. And I would expect that many of you in your life so far have actually probably experienced an allied health professional, or a member of your family or your friends will have. So if you have injured yourself playing sport, you might have gone to the hospital and had an x-ray and you would have seen an AHP. If you have ever been poorly, you might have been in hospital and you might have seen an AHP as part of that. So when I was younger, I was poorly and I had a poorly chest, and I had some physiotherapy with a respiratory physiotherapist. So lots of you will have encountered an AHP and perhaps not even known it. So I definitely lose your attention if I talk through every single AHP, but I am just going to read them to you, and so you know, you can have a bit of a think to see, actually, have I ever come across one of these professionals before? So the AHPs, you can see, hopefully you can see this slide, are all kind of listed around the edge. So I'm going to start with my favourite AHP, and I'm probably not really allowed to say that, but that's who I am. So that's a therapeutic radiographer. So that's one type of allied health professional. And also there's another type of radiographer called a diagnostic radiographer. And I'll tell you a bit more about diagnostic radiographers later, because we're going to have diagnostic radiography as a course here at the University of Lincoln, hopefully next year. Other allied health professionals will include dietitians, and hopefully you can have a good guess as to what a dietitian might do and where they might have a role. We have speech and language therapists, we have music therapists, we have paramedics. Lots of you will know who paramedics are, and they're playing a really important role, as are all of our allied health professionals at the moment. We have drama therapists, we have prosthetists and orthotists, art therapists, we have physiotherapists like Rowena, we have orthoptists, osteopaths, operating department practitioners, occupational therapists, and podiatrists. So it's by coincidence that lots of them start with an O or a P, and we won't test you because there's lots in there and there's lots to know. But basically, allied health professionals look after lots of people across lots of different healthcare pathways. Some people who might be very poorly, some people who are in rehabilitation for any reason. And so, yes, hopefully that's just kind of giving you a little bit of interest around who the allied health professions are. So what we're going to do now is a bit more kind of an interactive activity with you, which I'm going to hand over to Rowena to kickstart. And after we've done the activity, we'll come back to you at the end and just talk to you a little bit more about 4 of the different allied health professions in a bit more detail, just the ones that we offer here at Lincoln, and we can tell you a little bit more about. So thank you, Ro. I'm going to hand over to you.
Okay, thanks, Laura. And please, can you be my eyes and my ears?
I absolutely can.
As I go through this presentation. Thank you. Okay, so moving the slide on, I'm hoping, so first of all, hope you can see that. I'm hoping that you got the message about bringing a potato and hopefully some pens along to this session. So I hope you can see that on the video.
Yes, thank you.
And the reason for that was we were trying to make this session a bit more interactive, but also applied. So thinking about maybe how, as allied health professionals, we use our knowledge that we learn through our training, through our degrees, about maybe the different parts of the body systems and how the body works, to then think about how we use that to assess and manage or treat the people that we see or the people that we care for. So today we're thinking about the brain or a potato as the brain. So I've just put some learning objectives down for the session here. So hopefully we'll be able to understand some of the structures and functions of the brain, including some of the key divisions. So just really giving you a taste and introduction, how the brain coordinates and controls movement and functional activities, and thinking about how the impact of injury, insult or disease on the brain can affect, and then how actually as AHPs we get involved in the assessment, diagnosis of management of people who might have had some brain injury, insult or disease. So that's kind of hopefully what we're doing. And you can see on the slide there's a picture of some of our physiotherapy students. They're actually looking at different bones and joints there. But you can see that knowledge of anatomy and physiology or structural and function of the body is really important for our programmes. So to start with, just setting a bit of a scene and context for you. So some of you might already know this, but the brain and the spinal cord together make up what we call the central nervous system. So the brain sits inside our skull or the cranium, and then we have the spinal cord that sits inside the bones in our spine, so the vertebral column. And the brain is actually the largest organ that we have in our body, and it weighs about 1.5 kilos or about 3 pounds. And then we have, because the brain and the spinal cord are really important organs, they are surrounded with some protective fluid called cerebrospinal fluid that really helps protect them and cushion them and hopefully prevent any of those injury, insults or diseases as well. So what we're going to do is think about the brain as a potato, and hopefully get you thinking about some of the structures and learning a little bit about the brain. So to start with, if you have a look at your potato, basically the whole of that potato, if you're thinking about the brain, is what we call the cerebrum. And then if you draw a line down the middle of the brain or down your potato, you can divide the brain or the potato into 2 equal halves, or what we call hemispheres. So you'll have a right hemisphere and a left hemisphere. So what I would like you to do to start with is get your potato. Hopefully you've got some pens, preferably if you've got different colours, that would be helpful. But if you decide on a front and a back for your potato, so I've decided this is the front of my potato or my brain, and this is the back. What I want you to do is draw with your pen a line along halfway across your potato, so you're splitting it in half. Are we seeing that all right, Laura?
A little bit higher up.
Is that better? Can you see that better?
Yeah.
Yeah. So hopefully you've drawn a line from the front of your brain or your potato to the back. So what we're doing there is demarking the brain into 2 halves. So we're going to have a left side and a right side. So if I show you one, hoping you can see that I prepared earlier. Is that high enough, Laura?
Yeah.
Yeah. So you can see the black vertical line that I've put down the middle, and I split that into the left and the right side of the brain. So basically, we have the left and the right side of the brain have different functional specialities and do slightly different things. So, but we do use both parts of the brain all the time and for lots of different activities and almost everything we're doing. So right side of the brain is more associated with creativity, emotion, intuition, artistry, and visual spatial skills. And whereas the left side of the brain is more involved in language, maths, logic, science, all of those kind of things. And you can see a little bit on the slide there. And then we have in the middle, so thinking about the line that you've drawn down your potato to sort of split it into right and left, we have what's called the corpus callosum, which is a fibrous tract that kind of separates both sides, but also allows for communication across between both hemispheres. So thinking about what we're doing at the moment with our potato and our brain, I guess, or the whole of Science Week, we're thinking of using our left side of the brain because of science, and that's kind of what that side of the brain does. But we're also being creative with our pens, a little bit abstract, drawing our potato. So we are also using the right side of the brain. So now we're going to think about the lobes of the brain. So again, this is a kind of a division that we use for thinking about the different parts of the brain that have separate or different functions. So we have the frontal brain, the frontal lobe, which actually sits at the front of the brain. So thinking about your potato and your brain and which side you decided was the front, what I want you to do is about halfway across, so we're dividing probably about your potato in half, is mark what would be the frontal lobe. So it's halfway across there. And if you look up this potato I prepared earlier, the frontal lobe is the purple bit. And then past there, we're going to have the blue area, which is actually the parietal lobe. Sorry, my slides are skipping on, going back to there. And then at the back, if you draw like an oval or an egg shape, and I've done this in red here, that will denote the occipital lobe. And then on the sides of the brain, either side in green, I've got the temporal lobes. So what I want you to do now is have a bit of time splitting up your brain into those 4 sections. So you've got your frontal lobe, which is the purple bit at the front, which I say goes about halfway across. The parietal lobe in blue, sitting behind that. And then right at the back, thinking about the back of your skull, or where your occiput is, that's where your occipital lobe would be. And then at the sides, your temporal lobe. So hopefully you're able to do that okay. And so, like I said, different parts of the brain or different lobes do different things. So, for example, the frontal lobe, so sitting at the front of the brain here, tends to be involved in movement, planning, thinking, and executive control. And it's also kind of like our control panel for our personality. So sometimes if people have a problem with the side of the brain, maybe they've got a bit of a lesion or something, this can maybe impact or change their personality. If we go over to the blue part of the lobe, so the parietal lobe, this part here, this is really our sensory processing part of the brain. If we go back to the red area, like I say, at the back, the occipital lobe, that area is really key for vision. And then at the side, our temporal lobes are involved in auditory, so hearing, listening, and visual information, and kind of our multimedia system as well. And then we've got bits and pieces called fissures, gyrus, and sulci. I was thinking of a word then. So basically, there's lots of ridges and grooves all over the brain. This helps increases the surface area, but also these also demark or denote different areas. So the fissures will sort of split one part of the brain to another. So this longitudinal fissure here divides the brain into the left and right side, but then also you'll have fissures that sort of divide the different lobes.
Right, so I just want to pause for a moment and just let people catch up with their
absolutely
colours.
So give you time to catch up. Like I say, make yourself about halfway across the frontal lobe, and then the rest of the kind of the top bit there is your parietal lobe, and then your back sort of oval shape there would be your occipital lobe, and then down on the side the temporal lobes. So yeah, a few minutes to catch up with that.
I've just got my temporal lobes to colour, and then I've
good.
sorted my potato, and you can see that I am not an artist.
You'll have to take some photos or show me after, because it's really weird when you can't see anybody else.
Oh, of course you can't see it, can you, Ray?
I'm going to have to actually ask you to sort of help me out in terms of if you can see things in a minute, or I might just have to chop my potato in half and then show you the two halves.
Okay.
Do we think?
So I've got one more temporal bit, and then I think it might be good to move on.
Cool, thank you.
And then yeah, super. So I've coloured all of mine in Row. I don't know if you quickly want to whiz back through, because I think people might have been colouring and listening.
Yes.
And I struggle with that.
Yeah, so we're having to multitask as well. So yes, so just to recap then. So thinking about your brain, so this is the front of mine, so the anterior aspect. So the frontal lobe at the front in purple. So that's involved, it has lots of different functions, but movement, planning, thinking, executive control. Like I said, it's the control panel for our personality as well. So lots that the frontal lobe does. And then for me, I've done my parietal lobe in blue that fits across here, and that's really involved with sensory processing, anything sort of related to sensation, really. So that's the parietal lobe. And then our occipital lobe at the back, that's my red area here. That's involved in vision. And then at the side in green, sorry, it's a bit hard to see between the blue and the green. That's my temporal lobes on my potato, and they are involved in sort of auditory, so hearing, visual information, and those kind of things. Okay, fabulous. Are we happy to move on, do you think, Laura?
Yeah, I think so. Thanks, Ray.
Cool. Oh, I've lost my eyes. Okay, so we've sort of thought about some of the ways we maybe structure the brain or think about its functions, sort of on the kind of, I guess, more sort of the surface of the brain, really. But we do have structures that are sort of deep inside the brain as well. So I'm actually going to cut my potato in half. We've not asked you to have any knives or anything because we didn't want to do the risk assessment. So this is really just for me to do and then show you. So I'm actually just going to cut it. You probably can't see because my camera's probably a bit high. But for example, if we were to cut our potato into two, down the middle, thinking about maybe some of those deeper structures. I've put an example of some structures that might be sort of deep inside on the slide. So we have the diencephalon that is made up of the thalamus, the hypothalamus and the epithalamus. Please don't worry about all these big words, but it's just to sort of say, if you do go into maybe some of our HP courses down the line, that you will be learning about these kind of things. But really, these parts of the body are really key for maintaining our homeostasis. So keeping the body in balance, thinking about controlling body temperature, our metabolic rate, eating, our reproductive systems, and sleep wake cycles, all of those really important vital functions that we need. So that was just really to think about that there are things inside as well, and again, those structures within the brain have different functions too. So like I say, really important for homeostasis and those key vital functions there. And then if we think about our potato or our brain, we do have this cauliflower sort of shaped bit of the brain. If I get one of my models, so hopefully, can you see that anatomical model okay, Laura?
Yes, thank you.
Yeah, so now we're thinking about the cerebellum, which is this sort of cauliflower shaped bit or mini brain of the brain. So these bits here underneath. And the cerebellum is really important for sort of coordinating movements. Its name actually means little or small brain. So this is key, I guess, for particularly for myself in physiotherapy. You know, movement is our thing. So maybe people who have an injury to the cerebellum and it affects their movement, they might have a loss of their muscle tone, or they may be clumsy or more uncoordinated in their movements, and what we call sort of ataxia. We would be hoping to work with those people to try and improve their movements and make them more coordinated and less clumsy as possible. So that's the cerebellum for us. Okay. And then also going back to sort of our analogy of the brain being a potato, we have lots of layers in terms of where I guess the brain fits in terms of the skull, but the fact that, you know, we've got the skin that protects, then we've got the bone of the skull or the cranium, and then we've got these protective layers called meninges. So what I'm going to do now, again, I've not asked you to have a potato peeler with you, but again, thinking about the different layers involved, I'm just going to peel my potato to kind of show you or sort of reflect the fact that we do have those different layers. So I'm hoping that's coming across on the screen, Laura. Can you see that?
Right?
Yeah. Okay, so just peeling back, thinking about some of the layers. So like I say, you've got your skin first, and then you've got your bone, and then we've got the meninges. And really the meninges are there to protect the brain and the central nervous system, along with the cerebral spinal fluid. So you'd have those, and then obviously you've got your brain tissue or your cerebrum. Please feel free to chip in at any point, Laura, if you want to add anything else to what we're saying. Okay, so I guess that's kind of all I wanted to do in terms of some of the structure and some of the function. So hopefully that should give you a little bit of a taster. But like I say, you can maybe see in some of these anatomical models that we've got that there are lots of other bits inside the brain, and like I say, they all do very different important jobs. But I guess it's all right having this knowledge of organs like the brain, but for us as allied health professionals, particularly I guess some of us in therapy, it's thinking about then how that applies to working with our patients or the people we care for. So what I want to get you to think about now is you have been doing lots of different things as we've had this presentation, first of all, obviously you're watching the slides and seeing the visuals there. Obviously, you're also hearing or listening to us talk or our presentation, but you're also having to think about following instructions and doing a task of drawing and colouring in on your potato. So what I want you to have a think about is, and I guess maybe you can put some of your answers in the chat, what is the brain's role in the task that you have just undertaken? So thinking about back to trying to draw on your potato, the different areas of the brain, the different lobes, and colour those in, what's been the brain's role in that? What areas of the brain have you been using? Thinking about to some of the functions we've talked about. And what other body systems have you been using? So yes, your brain's been working, but what else has been working while you have been undertaking that task? And then perhaps thinking about maybe the role of a physiotherapist and occupational therapist, and how we maybe sit in that. But I'll talk about that. So I guess Laura, is it all right just to give people a few minutes to think about those questions and maybe see if there's anything in the chat?
Yeah. Ro, I'm guessing you can't see the chat, can you?
No.
So I'll tell you, we've got one person who's typing some things in. So we've got 2 suggestions. We've got the hippocampus and we've got the cerebral cortex.
Yeah.
So far. And we've got frontal lobe as another suggestion.
Yeah. Absolutely, thinking about what we were talking about in terms of planning, but also undertaking movement. Yeah. And the motor cortex. Yeah, for movement tasks. Yeah.
But I'm not sure, did we mention the hippocampus when you went through your slides?
We haven't mentioned the hippocampus today on the slides, no.
Yeah. Okay. Should we just give it another minute, Ray, to see if any other suggestions come in? Yeah. I think that might be it, Ray. I'm not sure whether we might have people who were kind of watching and not sat at their own computers.
That's
so that could well be why.
Yeah, so thank you to the people that have put in the chat in terms of the hippocampus. So yeah, that part of the brain is involved in sort of learning, but also memory. So yeah, absolutely. But in terms of, I guess, thinking about what other body systems, particularly from a physiotherapy and occupational therapy point of view, it's thinking about your musculoskeletal systems that, we are, or for me sitting here while you're watching, I'm needing my musculoskeletal system to keep me upright in terms of a good sitting posture and up against gravity. And also have that postural control in terms of my postural trunk muscles, but also head control. Obviously, my cardiovascular respiratory system's working as well. So although you might think about just, the brain, there is other systems working that we need to put together for all of these tasks. And I'm thinking in terms of peeling the potato or drawing on the potato, I guess is quite a fine motor skill, but you are relying on, like I say, posture, being upright against gravity, your muscles working, thinking about your joints, I guess, your joint range of movement, and also those muscles of the upper limb in this arm that's working, but also I'm using then my left upper limb to support the potato while I draw or write on the potato with my right upper limb, so those fine motor skills as well. But also thinking about sensation and also proprioception, so knowing where things are in my joints and that kind of thing. From an OT point of view, I guess they'll be thinking in terms of the grip, but the activity, how the person's doing it. Are they undertaking maybe any adaptive or compensatory movements to perform that task, really? And so what we kind of have a knowledge of is, I guess, is what we call sort of normal human movement or normal human function. So how things should work normally, and then how maybe we adapt or compensate should we have had an injury, illness, or disease. And for us as physios, we do a lot of sort of movement analysis. So thinking about what joints and muscles we use for specific tasks or activities, and then occupational therapists will do a lot of activity analysis. So again, thinking about the joints and the muscles, but also what sort of steps and processes and the order of completing a task come in as part of that activity analysis, really. So I hope that kind of makes sense. Okay, right. So then I was just sort of going to move on, Laura, as you're talking about, thinking about applying it more, I guess, into the roles of allied health professionals, and thinking about particularly the ones that we have currently in the School of Health and Social Care at the University of Lincoln, or ones that hopefully will be coming on board shortly, in terms of how we work in the assessment, diagnosis and management of people who might have had injury or insult or disease to the brain. So I don't know if we want to chip in on this bit together.
Yeah, we can do, and I guess oh, you might just have to move in between, Ro, because I can hear myself. So I wonder whether maybe if I just have a quick explanation about each of these professions very briefly first, and then I think we thought we might talk through perhaps somebody who's had a stroke and how kind of the different disciplines might be involved in the diagnosis and management of somebody with a stroke. So let's start with paramedics. It's probably an easy one. I'm fairly sure that you all know who paramedics are. There's lots of TV programs about them. For a start, they're a very popular allied health profession. So paramedics, I think often when we think about a paramedic, we think about trauma. And when there's been an accident or something fairly serious that's happened, and usually a paramedic is the first person on the scene to kind of assess and manage that situation. And that's still a really important role for paramedics, and they do, a fair amount of that, but they also work in lots of other different settings as well. So on the air ambulance, for example, you'd have paramedics working on the air ambulance. You also have paramedics working in doctors' surgeries, which might sound like a slightly strange location to have a paramedic, but they have a really big skill set. They know lots about kind of what we call pharmacology, around sort of the management of different drugs, etc. So they're very knowledgeable and can also work in kind of assessing a person who might come into a GP practice with symptoms that needs kind of quite a quick assessment. So paramedics might also work in hospitals. Again, that might seem like a slightly strange place to hear that a paramedic's working, but they do work in lots of different settings. And, you know, it's a 24/7 job. Paramedics do long shifts. Again, if any of you have watched the ambulance programme or 24 hours in A&E or anything, hopefully no one watches Casualty, I hope. But you'll get a bit of a feel for the fact that, you know, paramedics are not kind of fit into a lovely 9 till 5 box. And if that's the kind of job you want, then definitely don't become a paramedic. But yeah, we offer paramedic science at the University of Lincoln. You know when they're in the buildings, they're quite a noisy bunch. They're forever carrying equipment around. They're dressed as a paramedic from day one, so they've all got all their kit on. You can't miss them. And they're a great bunch of usually quite outgoing individuals who really want to kind of be at the forefront of managing sort of healthcare. So that's a little bit about paramedics. I think next on the list was radiographers. So if you can remember, about 35 minutes ago, I told you there's 2 types of radiographer. So there's a diagnostic radiographer and a therapeutic radiographer. And they kind of do what it says on the tin, really. So a diagnostic radiographer will do all of the different examinations and images, not examinations, images is the better word, will do all of the different images that they need that will enable a doctor to make a diagnosis of the problem. So if you hurt yourself playing rugby and you go to A&E, you're probably going to get an X-ray, have a little look at your bones. And we've got different types of images that will show us different bits of tissue. So X-rays are really good at showing bones. MRI scans are really good at showing us kind of soft tissue and that kind of fine detail. And we've got some other different imaging modalities as well. And so some people will just have one type of image. Some people will have a whole series of different images until we're able to diagnose, is there a problem here? And if so, what is that problem? In a case where that diagnosis might be a diagnosis of cancer, that's where we then see therapeutic radiographers. So therapeutic radiographers are a very specialised type of radiographer who are employed to deliver safe and effective radiotherapy treatment, which is using radiation, really kind of high energy radiation, to damage either cancer cells or the area where we thought there might have been cancer cells. And so the radiation breaks down the DNA in those cells, and the aim is that we hope that those cells will die and we've eradicated the tumour or the areas where the tumour was. And sometimes we can use radiotherapy to, rather than to cure a cancer, but we can use it to, you know, be about relieving pain or stopping somebody from being sick, or sometimes we can use it to stop bleeding. So there are 2 different degrees, which sometimes gets a bit confusing because people talk about radiography, but actually if you're a diagnostic radiographer, you do 1 degree or apprenticeship programme, and if you're a therapeutic radiographer, you do a completely different one. And apart from a teeny tiny bit of physics, and don't let that scare you, although it is Science Week, there's actually not that much that overlaps between the 2 professions. So I could talk to you about radiography all day because that's what I do, but I'm guessing it might be a teacher who's kindly asked if radiographers earn the most money, and I think the answer to that is no. They probably earn the least. They don't get much. A few years ago, they used to get nice sort of anti-social hours payments, but since the design of the NHS has changed to being 24/7, they don't get paid any extra. So yeah, no, unfortunately not. Whoever's asked that question. And then we've got physiotherapy and occupational therapy, and Ro has already kind of briefly mentioned that. And actually, it's probably better. I don't want to talk about Ro's profession on her behalf, so I might hand back to Ro for physio and OT overview, and then we'll have a bit of a think about somebody who might have had a stroke and where those 4 different professional groups might feature in the care of that person.
Yeah, thanks, Laura. So in terms of physiotherapy, we work in a variety of different places and across the lifespan. So from sort of antenatal, so before a child's born, all the way through to sort of end of life. Thinking about in terms of maybe the brain and stroke, for example. So if a person has had a stroke, which interrupts the blood supply to the brain, it can have a wide range of impact on a person's life. So it might be actually that it just sort of doesn't leave too many problems, or it might have quite a massive lifestyle change for an individual. So in terms of a physiotherapist role, we would work with an individual really early on, I guess, as soon as they're able to be, I guess, ready for some intervention from ourselves. So first of all, we would be assessing them and undertake an assessment to find out how that stroke had impacted on them, particularly in terms of their muscles and their bones. So muscle strength, their power, the joint range of movement, their muscle tone, their coordination, their movement, how they're able to walk, and things like that. But also it might be if somebody's quite unwell following a stroke early on, that we'll be actually working on just helping them with their breathing, so their respiratory function. So making sure we're sort of optimizing that respiratory and cardiovascular function status through positioning, through different techniques that we can do as well. So like I say, would be assessing them and working with them as soon as we really can after kind of diagnosis, I guess, through to hopefully getting somebody as independently as we can, or back to as much of their normal level as we can. So working with that individual in the hospital, but also then in the community. So maybe with a specialist team. We do have specialist stroke services and stroke units. So in the hospital, hopefully it would be working on stroke unit, and then community rehab teams or community stroke teams to input sort of in the longer term rehabilitation. Like I say, really to get somebody back to hopefully the level that they were at before in terms of their function. And we would work with somebody in terms of what they want to achieve. But normally, I guess for us, it's things like walking, or I don't know, maybe to drive again. Those are some of the key things. Being able to maybe use write again, if their upper limb's been affected, are some of the key goals that people might have. And then in terms of occupational therapy, there's quite a close overlap, I guess, between physiotherapists and occupational therapists. And we do work really closely together, often undertaking joint assessments and joint treatments as well. And really, I guess, for an occupational therapist, it's applying it in terms of the function of the individual and their occupation. And by that, they're kind of thinking about what's important to the individual. So again, it might be things like activities of daily living. So helping somebody maybe be able to get washed and dress themselves again after a stroke, or maybe it is around being able to peel a potato again and do some meal preparation with them, or it might be, like I say, returning to driving, or hopefully getting people back into work. So vocational occupational therapy. So yes, there was quite a big overlap, and like I say, we do try and work together as well.
Brilliant. So we've kind of talked there a bit about what happens when somebody's had a stroke and they're in hospital, and I guess we could just think a bit about the role of the paramedic and the radiographer before the physio and the OT. So I'm sure you'll all be aware that, I don't know if you've studied or looked at kind of what happens when somebody has a stroke, but I'm sure you'll have all seen or heard that it's an urgent situation, and we want people to get medical help as soon as possible when they have a stroke. And if you think about the role of the paramedic, what would ordinarily happen is that the paramedics would be called if somebody's at home or out of hospital having a stroke or have had a stroke. So they would usually be called first. They would be first on the scene. And what would be really important for a paramedic in that situation is to identify quite quickly if that person has had a stroke, or if something else is going on, because there are particular things that we need to do to then offer some treatment and try and sort of reduce the longer term impact that stroke might have. And the sooner that we can do that, the less likely we are to have some of the kind of long term problems. So they'll be first on the scene, they'll be assessing and trying to diagnose straight away, has this person had a stroke, and if so, they might offer some very immediate care before a very quick, speedy transport to hospital. And that kind of immediate care might be the administration of some drugs and kind of managing that patient situation. And again, there would be different severities. So you can have a very, very tiny stroke, and they might attend a person who thinks that they've had a stroke because they've got something, their face might be sort of drooping, or they've got a problem with one of their functions of their limb, but they're still, to some extent quite well, right through to attending somebody who's had a very serious stroke who might not be conscious and they might be dealing with that. So that's the role of the paramedic, first on scene, assessing what might have happened, making a judgment on that, and then administering that sort of immediate care before transport onto the hospital, always. So what's very important then is that once we think that person's had a stroke, it would be very difficult for us to absolutely confirm that without a whole set of images. And this is where we move from the role of the paramedic who's taken our person to the hospital, they've handed over to usually A&E when they arrive, and then the person who's then been admitted will have a whole series of different investigations. And so they'll have some blood tests, they'll have lots of different tests done, and some of those tests will be about imaging. So when a person has a stroke, that can actually happen for a couple of different reasons. So it might be that there's a blockage in the blood supply and that's caused a stroke, or it might be that a particular blood vessel has burst and that's kind of caused the problem. And so it's really important that we look at what's happened and where that problem is, and then try and think about how we might either try and reverse some of the problems that have been caused because of that, and equally how we might try and prevent that person from having another stroke. That's really, really important. And so we've got loads of different types of imaging that we can do. So we can do some different types of images where we can actually look at the vascular system, and really cleverly you can put a dye in and then image it and see whether there's a blockage, because if there's not a blockage, you'd see that dye disperse, and if not, it kind of gathers and collects. So we can look at the vascular system through a whole set of different images. And so the person who we've admitted to hospital will see the radiographer for that sort of imaging workup, and then they would receive a diagnosis, and that would be confirmed because of the imaging protocols that we've got. Then they'd have lots of other people involved in their care. We're obviously forgetting about the role of doctors here, we're forgetting about the role of the healthcare assistants, nurses. There'll be lots and lots of people involved in the management of a person who has had a suspected or confirmed stroke. But then, as Rose said, we would start to see the input from the physiotherapist and the occupational therapist around that person's function, and getting them up and moving and looking at the different body systems to make sure we're rehabilitating that person. What we should also have done, or what I could also have done, is talk to you about prevention of stroke. So way before our mystery person has had a mystery stroke, actually lots of strokes are preventable. And so there'll be a whole host of different healthcare professionals who might be involved in offering individuals sort of lifestyle advice, thinking about it. Sometimes people, not always, but sometimes people who have a stroke have got high blood pressure, and high blood pressure can sometimes be reduced and modified by different lifestyle behaviours. So I mean, it's just one example of many that we could have chosen, but hopefully it just gives you a bit of a flavour for where the allied health professionals, or the four that we've spoken about, so paramedic, radiographers, occupational therapists and physiotherapists, might feature in the care of a person. So yes, we predominantly work in the health sector, but you also have allied health professionals working in sports clubs, in private industry, in prisons, lots of different places where allied health professions work. So yeah, I appreciate we've given you lots of information today, but hopefully that's just given you a little bit of a flavour. If you want to look a little bit more about the role of the allied health professions, because there's obviously a whole, I think, about 10 or 11 that we haven't spoken about, there's a few places that I would direct you to have a look at. So if you look at the Health Education England careers site, there's lots on there about the AHPs, and also something called the WOW Show. And on the WOW Show, there's some really nice videos that you can have a little look at that tells you a bit about the different allied health professions as well. So that's it from me. Ro, anything you want to add or summarise?
No, just to say, I guess, thank you to everyone who's joined us and for listening, and hope you've enjoyed the session. So thank you, and enjoy the rest of Science Week.
Thank you, and thank you, Ro, for some epic arty skills with the potato, much better than mine. Thanks, everyone. Take care.
Thank you.